Thank you so much for being here and giving me the opportunity to present my work. My name is Giacomo Meille, and I'm a doctoral student at the University of Michigan. And today I'll be presenting my job market paper, which is about urgent care centers and how they affect spending and access of care. And as Jason and I were just talking about earlier, please feel free to interrupt with any questions as the presentation goes on. If we end up getting short on time, then I'll ask to kind of hold questions till the end. But for the moment, that's let's try doing that. And it's a little bit hard to see everybody on Zoom, so just feel free to ask your question kind of towards the end of the slide, and I'll also try to pause in a few sections for taking questions. Okay, so before I start going through my job market paper, I wanted to give you a little bit of background about myself. I'm a health economics researcher at Michigan, and my research studies healthcare utilization within the US, and I'm interested in a few different topic areas. So they are access to healthcare, healthcare delivery models, and mental health. My research papers that I've worked on cover a few different broad buckets. So I have a couple papers about prescription drug monitoring programs and how they affect opioid prescribing. And then a few additional papers about insurance coverage, one that looks at how insurance coverage affects prescription drug utilization for people with ADHD, and another one about the labor responses of hospitals in terms of hiring to the Medicaid expansion. Lastly, I'm interested in areas, so the healthcare delivery models, and my job market paper has to do with that. It's about urgent care centers, and that's what I'll be talking about today. The topic of the talk is understanding whether urgent care centers decrease spending and increase access to healthcare. So I'm just going to start with a little bit of motivation and a broad overview of the project before getting into the details with the data, results, and conceptual framework. One of the primary motivations for this project is that in the US, a lot of people report difficulties accessing care. And what I'm showing here is results from a survey done which compares the United States to 10 other developed countries. And there are a few different themes that emerge from here. Basically, the US is in the dark blue on these graphs, and the average of the 10 other developed countries is in the light blue. And so, first of all, in the US, financial barriers to care are a much bigger issue in terms of access to care than in other developed countries. Secondly, there are also issues with the convenience of accessing care. So a lot of people have to wait longer in the United States compared to other developed countries. And possibly in part because of these other two factors, the use of emergency departments in the US is much higher compared to other developed countries. So basically, these all reflect the difficulties accessing care within the US healthcare system. The other motivating factor is that in the US, the healthcare spending is extremely high compared to other countries, and these are the top 10 countries in terms of per capita healthcare spending from the OECD. Obviously, the US is way ahead, and while that's not necessarily a problem in and of itself, it is a problem if the spending is wasteful. And one of the areas in which people worry about wasteful healthcare spending in the US is with emergency department visits, which are very expensive places to treat conditions that could be treated by traditional primary care providers. So estimates are that about 30% of emergency department visits could be treated in other settings like physician offices. So that brings us to urgent care centers. And what these facilities are places where patients can get walk-in treatment and for conditions that are non-chronic and relatively low severity. And so what I mean by that, the examples would be things like a sinus infection or a cold, urinary tract infection, or a sprain. And so for these conditions, people can go to urgent care centers and get walk-in treatment. And why that's important is it's different from a traditional facility like a family medicine practice, where you have to book an appointment ahead of time and you might have to wait a week in order to get in and be seen. So it's more readily accessible care compared to those types of providers. And then relative to the emergency department, where you could normally go and get care on a walk-in basis, it's much cheaper for both the patient and the insurer to get treatment at an urgent care center. So that's broadly the differences. And if we go back to the motivational factors, in terms of spending, the hypothesis is that urgent care centers, to the extent that they get people to switch from emergency departments to urgent care, could potentially decrease spending in the US healthcare system. And then to the extent that they reduce some of the barriers to obtaining care by lowering the price of care relative to the emergency department and making care more convenient relative to physician offices, they could potentially increase access to care. So those are really the two questions that I'll be looking at. Now, the other reason why we care a lot about urgent care centers, or I think we should be more interested in them, is that the industry is very quickly growing in the US. And so while the primary care providers, so for example, family medicine physicians in the US over the past decade has mostly been close to constant, and other types of delivery models, like, for example, retail clinics where there's a nurse in a CVS, you might have heard that, something like that, or a pharmacy. CVS Minute Clinic is a big one that has received a lot of attention by economists. So while the number of those different types of places for getting primary care has really not expanded all that much in the past 10 years. And in contrast, the number of urgent cares has just increased tremendously. So this is really a changing part of the primary care market that I think we should be very interested in. So my strategy for understanding the effects of urgent care centers is to study entrance in Massachusetts, which is the state where there has been a real explosion in terms of the number of primary of urgent care centers. So during the period that I'm going to look at, there was an increase of about 80% over just 4 years in terms of the number of urgent care centers in Massachusetts. So it's a great state to study, and I'll be using a difference in differences model that compares patterns of healthcare utilization and aggregate spending for those zip codes that are located near the urgent care center openings, and comparing them to zip codes that are located further away, which form the control group. So that's the basic way that I'll be structuring the study. All right, let me just stop here in case there's any questions at this point. I think it'd be a great time to hear from anyone.
I have a quick question, Giacomo.
Sure.
So you've talked a lot about these as in terms of the spending on them. Can you talk about the relative differences in sort of quality and type of care that they provide relative to other clinics?
Definitely, yeah. So there's been some interest in that aspect too, especially from physicians. We don't really know whether urgent care centers provide higher or lower quality of care. And that's kind of an open question that could very well influence the effects on healthcare utilization and spending. And so when I talk about the conceptual framework, that's something that I'll be also considering in terms of what the effects might be there. But generally, in terms of what the differences are, in terms of how they're set up, urgent care centers typically have one physician that's in there at a time. If it's a particularly large center, they might have 2 on staff at a given time. And they're generally supported by a set of nurse practitioners and also physician assistants. So there's a little bit more reliance on the support staff compared to an emergency department. And that's kind of one of the reasons why the price is so much lower compared to an emergency department. Also, the salaries tend to be lower in urgent care centers compared to emergency departments. And another factor is that because the urgent care centers focus on treating people with these non-chronic, low-severity conditions, they tend to have medical equipment and capabilities on site that are really targeted towards that. So when you go to a usual primary care provider, they might not have like an X-ray machine in their office, for example. You might have to be referred somewhere else to have that taken care of. But because urgent care centers really focus on these types of conditions, they pretty much all have X-ray machines in their facilities, and also they have laboratory testing capabilities, basically in order to treat those types of conditions. So again, it's really hard to know ex ante whether they provide higher or lower quality of care. They certainly specialize in treating these types of conditions, and you could make an argument that for those types of conditions, they might actually be better set up to deal with them. You could also, on the other hand, make an argument that they hire lower quality staff. We just don't know.
Do we know whether they draw on similar patient populations in comparison to other places, in the sense that, like, you know, insurance coverage, and whether that makes people more or less likely to utilize these clinics versus others?
Yeah, absolutely. So for urgent care centers, they are not like emergency departments where they're required to stabilize all patients regardless of insurance status. Urgent care centers are generally for profit and tend to have restrictions on the type of insurance that they accept. And for that reason, in the study, I'm going to be focusing on people with private insurance. But I think basically it varies. In some areas, urgent care centers also take Medicaid, and compared to the emergency department, the population that is covered by Medicaid is generally lower in urgent care centers, just as a baseline high-level comparison. And I think it's probably quite in line with what you would expect at more traditional providers who also have the same kind of flexibility in terms of determining who their patients are.
Great, thanks.
Sure.
One maybe short question you might wait for until later, but out-of-pocket expenditures from the patient across those 3 types of visits?
Yeah, I'll get there. I have a slide on that, so I'll just get us there, and we can talk about that.
Thanks very much.
Great. Okay, so in terms of the contributions of this paper, it's really the first one to look at the effect of urgent care centers on the broader primary care market. So in previous studies, there's not a whole lot of literature about about urgent care centers, but what literature there is has focused exclusively on the effect on emergency department visits. And I'll be taking a much broader view here. So I'll be looking at the effect on urgent care visits, on substitution away from emergency departments, but also substitution away from other different types of providers like traditional family medicine practices. And I think it's really valuable to look at that broader set of of the primary care market in terms of where people get treatment for these kinds of conditions, because if we're interested in questions like aggregate utilization and aggregate spending, we need to look at the entire market. And so that's what I'm going to do in this paper. So just as a preview of my results, I find that in areas that are, so in zip codes that are close to urgent care entry or urgent care openings, there is an increase in utilization of urgent care centers. But the majority of that is offset by decreases in visits to other different types of providers. So primarily, there's a pretty large decrease in visits to traditional offices, and there's also a small decrease in emergency department visits. So on aggregate, the effects on spending are a small decrease in spending because the decrease in ED visits is also small, and that's where the biggest price differential lies. In terms of utilization, the effects are really actually very heterogeneous. So in areas where there are few primary care providers per capita, in those areas, it's primarily a substitution story where pretty much all of the additional visits to urgent care centers reflect substitution away from traditional primary care providers. But in areas where there are few primary care providers per capita, urgent care centers actually increase utilization. And so in those areas, there's less substitution, and there's evidence that possibly because there might be capacity constraints by the supply of physicians in those areas, when an urgent care enters the market, the overall healthcare utilization for primary care treatable conditions increases. Okay, so next I'll talk you through the conceptual framework before moving on to the data and results. And so I'm interested in the effect on healthcare utilization and spending. And so I find it useful to think about three different variables, which are the number of episodes treated in the healthcare system. And what I mean by the number of an episode of care is basically for a person with a given condition, all the visits to different providers for that condition. So say you have a urinary tract infection and you go into an urgent care center, and maybe you get prescribed an antibiotic for it, and urine culture gets taken. If the tests on the urine culture come back and it seems like a different antibiotic might be more appropriate, you might end up going in a second time and getting a prescription for a different antibiotic. And those two visits together would constitute the episode of care for that condition. So basically, I'm looking, the three variables are the number of episodes, the number of visits per episode, and when you multiply those two together, you would get the total number of visits, which is my measure of utilization that I'll be using, and then the price per visit. And if you multiply all three together, you get spending, which is my other metric that I'm interested in. So I'm going to be talking through how urgent care center openings affect each of these three different variables, and showing some arrows on this slide, which you can basically think of as partial derivatives if you're so inclined. But basically, when an urgent care center opens, the consumers that are located, or patients that are located nearby, have an additional option. And so we generally think that that's going to increase the number of episodes in the healthcare system. And that's what that upward arrow means. If we move on to visits per episode, this is where quality of care could increase or decrease at urgent care centers compared to other types of providers, right? We really don't know whether they provide higher or lower quality of care. But if, for example, they provide lower quality of care, which has been the worry of some physicians out there, then it might take more visits to treat a particular condition because the quality of care is lower. So that could potentially increase the visits per episodes But again, we really don't know whether that's going to have a positive or negative effect. There's also possibilities that they could be better than other types of providers at treating these conditions because they're really specialized in treating them. So the second way that the number of visits per episode could be affected is that if people get in to see providers earlier, because urgent care centers are more easy to access and you don't have to wait as long for appointment times, then they could potentially be coming in with less severe versions of their conditions. And if that's the case, then it also might take fewer visits to treat a particular condition that a person has, and that could place a downward effect on the visits per episode. And so if we go back to the effect on utilization, the effect could be positive or negative. We generally expect that the number of episodes is going to go up, and the visits per episode could potentially go up or down. And so, we really need an empirical study in order to understand what that effect will be. With respect to price per visit, what I'm primarily going to focus on is this first point, that substitutions from emergency departments to urgent care centers could reduce the average price per visit, just because emergency departments are so much more expensive for treating primary care conditions compared to an urgent care center. So to the extent that that happens, the average price per visit will fall. And then another potential channel through which price per visit could change from urgent care entry is because of increased competition, prices could fall.
Giacomo, can I ask you something real quick?
Yeah, sure, go ahead.
Does it matter for this or for your subsequent work whether people are just individually choosing to go to an urgent care center as just sort of a matter of personal preference or cost, or whether they are being directed there by the fact that, say, there are no appointments available at their usual doctor's office?
Yeah, so I think it does matter. It certainly changes the effects that we would expect to measure. If everybody is being directed there, and there are very strong incentives from the insurer and that push people there, then the magnitudes of the effect could be much larger compared to if it's just a personal preference kind of thing. So I think it certainly does affect the measurements that I'm making in terms of the effect on both utilization of care and cost to the healthcare system. Those are important points.
So would that be something that you could account for in this work, like depending on the structure of your data, or is that just sort of?
Yeah, no, I think that's a really interesting question, one that I haven't looked into at this point, but one of the great things about the data that I'm going to be using, which is insurance records, claims data, is that I see the patient copays and the insurer spending separately. And so I could potentially look at, patients who have different types of plans in terms of, what their copays are, and then also what their deductibles are. I recently got kind of a new file that gives me kind of more insight into the patient plan, and I could see what the total deductible is for the year for the patient, for example, and that could be a really interesting source of heterogeneity to look at in future work.
Yeah, it might just be particularly important given that you said that your data is primarily concerned with a situation where these centers are new, right? Newly opened, yeah. Because people likely don't know about them until they are in a situation where they would like to go to the doctor, but the doctor doesn't have any appointments available, right? And a suggestion is made, oh, you could consider this urgent care clinic instead as an option. So particularly for the time period where you're looking at when it's a new entry into the market, it seems like this could be significant.
Yeah, that's a great point. I'll definitely, that's new data that I have, and I think that's a great new direction that I could look into to help make the work kind of speak to those issues as well.
I have one kind of off the track question
Yeah.
from curiosity more than anything. If you
Mhm.
think about all these new clinics, I guess I just don't have a sense of where these doctors and staff are coming from.
Yeah. So my best understanding of that is that it's primarily doctors who are moving from more traditional models of care to opening up urgent care centers in order to do that. Because the supply of primary care or general practitioner physicians within Massachusetts during these years did not change very much. So my understanding is that it's really a change in the model of delivery within the healthcare system rather than a lot of new doctors kind of moving into Massachusetts and deciding to opening up these types of practices.
This might come back when you interpret your results, but like that type of substitution suggests that like the treatment of a new clinic opening is also related to a doctor that used to be maybe in the emergency room no longer being in the emergency room, or a doctor who was in family practice, further limiting the supply of family practice because they're making this switch.
Yeah, that's definitely possible. And so you could, that's definitely possible and an interpretation that you could bring to the results. And I think to the extent that making these types of switches and changing the models of care delivery increases efficiency within the healthcare system, that could be a good thing. If you can get people out of the emergency department, that's generally a good thing for a variety of reasons, not just cost related, but there's all types of other improvements in terms of reducing things like waiting times within the emergency department, also reducing patient exposure to potentially other types of diseases. For example, like right now with COVID, nobody really wants to be in an emergency department waiting room. You'd rather get in and out very quickly. So yeah, that's definitely an important thing to bear in mind when we look at these results. All right, so beyond that, the second other thing that I'll be looking at is heterogeneity based on access to primary care physicians. And so I'll be splitting the sample with which I work with into areas that are above and below the median level of primary care physicians per capita in Massachusetts. And generally what we would expect is that in areas with fewer primary care physicians, an urgent care opening would have a greater effect in terms of more use of urgent care centers, kind of all else equal, because there are fewer other options available and less of substitution away from other types of primary care practices like family medicine. Also, if there are capacity constraints within the healthcare system, this is really where we would expect to see them because there's fewer primary care physicians in such areas. And that's where we would expect to see increases in utilization if they happen anywhere because of issues related to access to care and capacity. Great. So next I'm going to take you through the data here before moving on to the results. I'm sorry, I can't see the time, but I just will double check really quickly here. Okay, we're in about half an hour. So great. So one of the things that has made it difficult to do research on urgent care centers in the past is that it's very hard to gather data about them. So urgent care centers are owned by a wide variety of different types of practitioners. So some are owned by hospitals, some are chains of urgent care centers, and others are just kind of individual physician groups or a community health center that might open up an urgent care center on the side of its main practice. And so what I've done is invested a lot of time into assembling this database of urgent care center openings in Massachusetts, and primarily getting data on three different things: location, opening dates, and national provider identifiers, so that I can then go and link the urgent care centers to insurance claims data that I'm going to use to look at utilization and spending. When we assemble this database, we really get a sense of the fast expansion of the industry within Massachusetts during the years that I'm looking at. So I'm going to be studying 2012 to 2015, and kind of the blue and the very small number of green dots in this picture represent the areas where urgent care centers opened up or were already open in 2012. The green represent the urgent care centers that closed by 2015. There were very few of them. By and large, most of them who were operating in 2012 were still operating in 2015. And then the red dots represent the ones that opened between 2012 and 2015. And so overall, there was a really large increase in the number of urgent care centers in Massachusetts during just these 4 years. And if we look at the map, we can also see that that increase was increased kind of the spatial distribution of urgent care centers too, so that areas that previously didn't have an urgent care center nearby gained access to one during these years. So kind of at a zip code level, if we look at the percentage of zip codes based on the distance to the nearest urgent care center, the zip codes located near an urgent care center increased by a lot during these 4 years. So the number within 2 miles increased by 8 percentage points, from 22% to 30%, and the number within 2 to 5 miles increased by 3 percentage points. So overall, we're talking about an 11 percentage point increase in the number of zip codes that are within 5 miles of an urgent care center during just 4 years. All right, so with this great data on urgent care centers that I open, I merge that with data from the Massachusetts All-Payer Claims database in order to study the effects on utilization and spending. And so this is a data set that I'm going to use to study all people with private insurance in Massachusetts. And I'm going to focus on people under 65 because it doesn't include Medicare. And that population is primarily insured by Medicare. So I'm going to focus on the people under 65. The outcomes that I'm going to measure are at the zip code by month level. And I'm going to be looking at the number of visits by provider type and dividing providers into 3 different categories. So urgent care centers, emergency departments, and other outpatient facilities like family medicine practices. And then in terms of spending, I'll be looking both at insurer spending and patient spending. So within this broad set of insurance claims, I'm looking at 2 types of conditions. And my primary focus, and pretty much every slide that you're going to see from here on out, unless I otherwise say so, is these primary care treatable conditions. So these are the low severity, non-chronic conditions that urgent care centers are really set up to treat. And then I'll be looking at also a set of emergent conditions, which are also non-chronic, but are high severity. as a placebo group. So I have one slide on that, kind of looking at what happens when urgent care is open up to treatment for those categories of conditions. But broadly speaking, these sets of conditions are not meant to be exhaustive in terms of representing all primary care treatable conditions, but they're meant to capture a large portion of them. And basically what I did is I looked at previous work, used their sets of primary care treatable conditions, and also included other condition codes that were in the top 10 of urgent care, of the types of conditions that urgent care centers tend to treat. And so in these columns on the right, they add up to 100%. And what that's telling us is that about 50% of urgent care center visits fall into this category of the primary care treatable conditions that I'm looking at. So again, they're meant to be representative of that type of condition, not fully capture every single condition, but we're still working with a very large set of conditions in terms of the overall number of visits that they account for. They also account for a large segment of emergency department visits. So these set of conditions account for about a quarter of emergency department visits. And so to the extent that urgent care centers are able to decrease emergency department visits, there could be potentially large savings to the healthcare system if I were to find, just by looking at these conditions, that the openings are able to shift people from emergency departments to urgent care, just because there's such a large, they account for, fully a quarter of emergency department visits. On the emergent visits, those are very, very rarely seen in the urgent care setting. And some of that is just the fact that these are, there are fewer of these conditions, and so the number is smaller. But if we compare the number that are seen in the emergency department, for example, that's a larger fraction of ED cases, and that's exactly what we'd expect, because these are high severity conditions that you would want to go to an emergency department for. Great. And lastly, getting to that question about how insurers versus patient costs. So this is the average spending for a visit for one of these primary care treatable conditions at each of these different types of providers. Basically, this mirrors the data from earlier that I showed in the slide about urgent care centers. And those emergency department visits are just much more expensive, both for the insurer and the patient, for the set of primary care treatable conditions that I'm focusing on.
I have a quick question about just where the data would come from for the patient side of, say, the urgent care center. Is that like posted on the website, or is this from any kind of urgent care center records of any sort?
So this is all data in terms of utilization and spending, which I'm taking directly from the insurance claims data from the Massachusetts all-payer claims data set. And so this is the insurer record of how much we charge the patient in terms of co-pays, deductibles, anything else that you could potentially have to pay out of pocket.
So it's conditional on the patient. I'm trying to think through. So if you're insured, but you don't file a claim with your insurer and you just pay it out of pocket, that's not here at all.
No, yeah, I mean, that's the limitation of this data set. It does capture a very large percentage, I would think, of visits from people with insurance coverage, but in the case that you don't report it, it's not going to be in here.
Do you know offhand, because I've been to urgent care centers, maybe I just didn't take the next step where I would go back to my insurer and say, hey, I was, there. Is that what it would take? Would be me to contact my private health insurer and say like, hey, I did this, it cost $100 out of pocket, and I give them a receipt and they figure out whether any of it could be reimbursed?
Yeah, so for most of the urgent care centers, they all have billing departments and will tell you which insurers they work with and kind of do that automatically. I think in some cases, patients might have to do that on their own, and they're definitely incentivized to do that to the extent that insurers pay for the visits. And you can see here in terms of the breakdown in spending, insurers pick up about it looks like 75% of the tab, and so it certainly looks like patients are either reporting those visits to insurers, or probably most likely with the vast majority of urgent care centers, they're kind of automatically doing that through their billing.
Thanks very much.
Yeah.
I have a quick question about the structure of urgent care centers. Do you know that like all urgent care centers are kind of like created equal? Like, are there some with like a huge, number of exam rooms and others that only have like 2 or 3? Or is there any kind of internal variance there?
There's a ton of internal variance there. And a lot of that even has to do with the ownership of them. So some urgent care centers are owned by hospitals, and basically what they'll do is they'll send some of their ER physicians to do a rotation there, or kind of like a once a week kind of thing, or maybe a full week where they'll work there, and the setup will be different as well. There's a little bit of standardization because the chains play an important role in the urgent care market, but there's also kind of one-offs. And so there's definitely heterogeneity, but most of them, I would say, kind of tend to be either operated by chains and have kind of a usual type of setup, or what a lot of even the hospitals have done that are opening urgent care centers is they'll work in partnership with established urgent care center providers in order to open one of these up. And to the extent that they're working with somebody who already has kind of standard model of how to open up an urgent care center, that's going to increase the standardization of these urgent care centers.
Thank you.
Yeah. Great. So I think at this point we can probably move into the empirical strategies and also the results. So in terms of the ideal experiment that I would like to run is to randomly assign urgent care centers to zip codes within Massachusetts and measure the effects of my 2 outcome variables, which are going to be the number of visits per 1,000 people with insurance and spending per 1,000 people with insurance. Of course, if we go back to that map, urgent care centers are not distributed randomly. They tend to be in areas that are either urban or suburban. And because of that, if we were to run kind of just OLS regression on the location of urgent care centers, on healthcare spending and utilization, we would find positive correlations. And that's just because they tend to locate in areas that have higher utilization of care. So that motivates the difference in differences model that I'll be using. And this is a fairly standard model where the outcomes are measured as a function of zip code fixed effects, time fixed effects, a treatment variable, which is an indicator. So at least this is the primary specification, which will be, or baseline specification, which is an indicator for whether or not there's an urgent care center within 5 miles of a zip code, and then controls for the other types of providers within a zip code. And here in the Massachusetts context, you should really think of this as boiling down to openings of retail clinics. So during this time period, there was an expansion in the number of retail clinics in Massachusetts at the same time, and I'm accounting for that in these covariates. You really don't have very much change in terms of emergency departments in Massachusetts. That was extremely stable during this time period. Pretty much all of them remained open. Yeah, that's the basic model that I'm using. One of the great reasons for working with Massachusetts is that using this difference in differences strategy, the threats to identifications are really minimized compared to working with other states. So urgent care centers expanded very quickly during this time period. So we have high amounts of variation in the variable that we care about. And this is a relatively short time period. So it's unlikely that there's going to be very large changes in demographic factors over such a short time period. Now, with that said, different policies related to healthcare could definitely change patterns of healthcare utilization during this period. But one of the great things, or another great thing about working with Massachusetts is that while the rest of the United States experienced a really large increase in the share of the population that was insured between 2012 and 2015 because of the ACA, in Massachusetts, they expanded insurance coverage earlier, prior to 2010. And so the insurance coverage barely changed during these 4 years. The percentage of people with insurance coverage under 65 increased only by 1 percentage point in Massachusetts. And so the effects of the ACA are really minimized by looking at Massachusetts, and it's kind of a cleaner state to study compared to other states during this period. With that said, there are still potential threats to identification with this difference in differences strategy. For example, the parallel trends assumption for difference in differences could be potentially violated if urgent care centers enter more profitable markets first, or if they enter markets where visits or spending are growing fastest. And for that reason, I'm also, in addition to doing the difference in differences analysis, going to start off with an event study so that I can kind of empirically test whether it looks like the difference in differences assumptions seem reasonable or not. And so this is an event study model that I'll be using, where basically I'll be comparing the zip codes that were treated, so where urgent care centers enter the market relative to the control zip codes at different moments in time relative to the opening date of that urgent care center, in order to provide evidence for whether it looks like the parallel trends assumption is reasonable in the pre-period at the very least, and then whether the treatment that I'm measuring coincides with the timing of the urgent care center openings. Okay, so that's the empirical strategy. Let me take a pause again here in case there's any other questions before talking through the results. All right, well, feel free to stop me again as we go through these results, but I'll get started then with the event study analyses before moving on to the difference in differences model. Okay, so again, looking at these event study models, the primary thing that I'm using them for is to assess whether the pre-trends look good. So basically what I'm hoping to find is that before the opening, which is represented by this red vertical line in each of these graphs, that hopefully the coefficients are close to zero, so not statistically significant and don't look like they're all that trended. And then secondly, I'm using the then studies to look and see whether the treatment corresponds with the timing of opening. And so broadly speaking, it certainly looks so. So on the left-hand side, you see urgent care visits, and it looks like the treatment and control zip codes are trended pretty similarly in the pre-period, and then after the opening, you have a big increase in the number of urgent care visits in the treated zip codes relative to the control zip codes. And then in the emergency department visits, which are on the right, that's a little bit noisier, but broadly, it looks like the assumptions are relatively good there too. We don't see, we see kind of the same insignificant estimates in the pre-period, and then a drop in the number of emergency department visits in the post-period. Not all of these coefficients are statistically significant in the post-period, but these are monthly estimates of the effect of urgent care centers. And so in the difference in difference framework, we're going to kind of jointly test whether those are a significant reduction in the number of visits to emergency departments. The other two outcomes are other outpatient provider visits. And again, there it looks like there's not too much of a pre-trend and then a reduction in other outpatient visits after the urgent care opens. And the last one is total visits. And there it really doesn't look like anything happens when an urgent care center opens. There's no evidence that there's an increase in total visits. So broadly speaking, I think this then study provides pretty good evidence that difference in difference design looks like a good way to measure the effect of urgent care center openings. The parallel pre-trends assumption looks pretty good, and the timing of the effects coincide with the urgent care center openings where there are any. Okay. So that brings us to the difference in differences model. And this first model just uses an indicator for whether there's any urgent care center within 5 miles. And what we see is that in the zip codes that are located nearby, when an urgent care center opens, you have an increase in urgent care center visits and a decrease in substitution away from emergency department visits and other outpatient providers. And primarily, the decrease is from substitution away from other outpatient providers. And when you add the two up, basically on net, the effect on total visits is a positive but statistically insignificant or not statistically significant estimate in terms of the total effect on utilization. So in order to provide a little bit more evidence, I also look at the number of urgent care centers within 5 miles. And these estimates should be interpreted as, so this is actually basically a categorical variable for the number of urgent care centers. So these estimates should be interpreted as the total effect of having 4 urgent care centers or 3 urgent care centers, not an incremental effect. But basically, as the number of urgent care centers grows, the number of visits also grows, and the substitution away from other outpatient providers increases. So we have less visits to other traditional providers. And in terms of the total number of visits, regardless of the number of urgent care centers within 5 miles, the estimate is not statistically significant. Lastly, I do a difference in differences estimate based on the distance to the closest urgent care center. And so this looks at different thresholds of difference, of distance. And so I have zip codes that are within 2 miles, zip codes that are 2 to 5 miles away, and 5 to 10 miles away. And broadly speaking, the closer the zip code is to an urgent care center, the higher the effect is, or the greater the effect is, which makes perfect sense. And actually, within the rest of the talk, this is actually my preferred specification, because what we learned from this is even those zip codes that are 5 to 10 miles away from the nearest urgent care center, those zip codes, the effect is small but statistically significant. So it's not ideal to include those zip codes in the control group. And so for that reason, this is really my preferred specification when I look at the effect of urgent care entry. Okay, now I'm going to move to heterogeneity, and this is where I was talking earlier about the heterogeneity based on the number of primary care physicians in the zip code. And here, basically for every zip code, I'm taking a 5-mile radius and seeing what the ratio of the number of primary care physicians is to the population in that radius. And I'm dividing zip codes based on whether they fall above or below the median in Massachusetts. And to give you a sense of what that means, because Massachusetts is a state with lots of primary care physicians or physicians in general, in the areas with fewer primary care physicians per capita, so the ones that fall below the median, about half of those would qualify as having a physician shortage for primary care physicians. So really, there is a large difference between the access to primary care providers in these two subsamples. Okay, the first group that I'm looking at is the areas that are above the median. So they have high numbers of primary care physicians per capita. And in these areas, you see an increase in urgent care visits when an urgent care center enters the market, and substitution, or a large amount of substitution away from other outpatient providers. And so on net, the estimate in terms of total visits actually end up being negative point estimates that are not statistically significant. And so in these areas, it's really a substitution story where people, or urgent care center opens and people switch from traditional primary care practices to urgent care centers. On the other hand, the results are really different in areas with few primary care physicians per capita. And so in these areas, there's both a larger increase in urgent care center visits and much less substitution away from other outpatient providers. And so if we look at the net effect on the total visits, all of those estimates are either statistically significant at the 5% level or the 10% level. And if I were to show you some of the other specifications that are included in the paper, it's quite convincing that in these areas with few primary care providers per capita, there's an increase in utilization of care when an urgent care center opens up nearby. And so what that's broadly telling us, I think, has important policy implications, which is that basically in these areas, it seems like there are capacity constraints with respect to the number of physicians. And when urgent care centers open up, they're able to alleviate some of those constraints and increase access to care or utilization of care in these areas with fewer primary care physicians per capita. All right, any questions at this point?
One question, you might have already mentioned this, but how many zip codes are treated multiple times in multiple ways?
Right. Oh, so I think that goes back to that graph that I was or that I was showing that kind of splits the number of zip codes based on how far they are from an urgent care center earlier on. And so there's really quite a lot of zip codes where they go from not having an urgent care center within 2 miles to having one open up there. I think of the slide showed that there was that number increased by 5 percentage points during these 4 years. And in terms of the number of zip codes in Massachusetts, there are 530 zip codes or zip code tabulation areas is what I'm actually using, kind of the census.
But it's allowed here that a clinic can open both inside 2 miles, and then a separate clinic can open up outside, like between 5 and 10, and those are both in here.
Yeah. So, but here I'm exactly here. I'm just categorizing them by what's the closest urgent care center, and so you get categorized as either the closest one is within 2 miles, or the closest one is within 2 to 5 miles. But basically, it's one or the other, not both.
But I guess would it be true that a zip code could start with an opening between 5 and 10 and then work its way down, but it can't do the opposite?
That's right. Yeah, unless the closest one closes.
Right. Yep.
Which is very uncommon. All right, so I'll just continue, and the next thing that I'm looking at here is the placebo. So this goes back to those sets of emergent conditions. Here it might look like I'm actually zooming out of this picture to make these coefficient estimates look really small, but that's not the case. I'm actually zooming in on it. So if you looked at the scale compared to before, this is a kind of blown up graph measuring the effect of the urgent care entry on the emergent visits. And what's apparent from that is these estimates are really small in terms of the point estimates. And so I think broadly speaking, the placebo should be pretty convincing that urgent care centers don't have much of effect in terms of emergency department visits, other outpatient visits, or total visits. In percentage terms, there is like a small number of cases where people go to an urgent care center for emergent condition, and so that looks like a really big increase in terms of a percent increase, but it's off of an extraordinarily small base. And so in general, urgent care center openings really do not affect visits for emergent conditions. And that's what this is showing here. And I think the reason why this is useful to do is because if, for example, population was driving these results, right, and urgent care centers were just opening up in areas where the population was growing the fastest, then you might expect that these emergent visits might also be correlated with urgent care openings, but that's really not the case. So I think the empirical strategy from that point of view looks pretty solid. Okay. Lastly, I'm going to talk about the effects on spending. And here I'll just start with a back of the envelope calculation where to give us some sense of what we should expect. What I do is I take the estimates from the estimated change in the number of visits for those areas that are most affected, so within 2 miles of an urgent care center, and apply just the average price per visit at each type of provider in order to get a sense of what we should expect from the visits analysis in terms of the effect on spending. And what this is going to do is increase that number for the emergency department visits because the price per visit is very high. And so if we tally all this up, it looks like the net effect on urgent care center openings on spending is a overall decrease in spending. So broadly speaking, this gives us a sense of what to expect, but it's not the ideal way to measure this because the patient case mix could potentially change. And so just to give you an example, maybe there's that decrease in emergency department visits, but those even within this category of primary care treatable conditions, those might be people who have the lowest severity cases. And so it might not be ideal to apply the average price per visit from the emergency department visit. And so instead, I also measure directly the effect on spending in the same kind of difference in differences framework. And this shows the results here. And basically, we see sort of the same patterns with an increase in urgent care spending, decreases in emergency department and other outpatient spending, which are, again, significant either at the 5 or 10% level. And then in terms of the net spending, the estimated coefficient is negative, but not statistically significant. So I would say that overall there's weak evidence, but it points to the direction that urgent care centers probably decrease spending in the areas that are most affected. And if we were to take that lower bound of the confidence interval, whoops, we're going the wrong way. But if we were to take the lower bound of the confidence interval, that suggests that at a maximum, the net spending for urgent care centers, that urgent care centers decrease net spending by a maximum of about 2% for primary care treatable conditions. Okay, so let me leave you with a few takeaways from this project. So first of all, I find substantial substitution away from traditional outpatient providers to urgent care centers. And that's important because basically, to the extent that this is what's happening when an urgent care center opens, it's not going to have much of an effect on spending. And sorry, let me just take a look at how we're doing on time. Okay, we're good. So, so basically, to the extent that this is what's happening when urgent care centers open, that's not going to affect spending that much because the price per visit is very similar at these two types of providers. But I think it's also worth noting because it's a lot, you don't have to schedule appointments in advance at urgent care centers. And so there could still be important improvements in patient welfare from the switch because people, the waiting times for an appointment decrease. Secondly, there's a modest decrease in emergency department visits. And so for those set of primary care treatable conditions, the emergency department visits decline by 8% in the zip codes that are most affected. So the ones that are within 2 miles of an urgent care center opening. And to give you some context about what that means in the larger scope of ED visits, those primary care treatable conditions made up a quarter of emergency department visits. So we're talking about a 2% decrease in the number of visits to emergency departments by people who are located closest to urgent care center openings. And to the extent that that happens, that's important because it's much cheaper to treat people in urgent care compared to the emergency department, and because it could have effects like reducing ED crowding, wait times, and exposure to things like COVID when you're in a waiting room. But basically, this is a relatively small effect, and when people talk about urgent cares or other types of models of delivery of care, like this is kind of we shouldn't expect that this is a silver bullet that's going to that's going to solve all of our problems with care being or emergency departments being overutilized for primary care treatable conditions. It's really something that we should be using in conjunction with other different types of policies to reduce those types of visits. And lastly, what I find is a moderate increase in visits in areas with few primary care physicians, but no effect in areas with more primary care physicians. And because there's no effect in terms of the number of visits in areas with more primary care physicians, but there is substitution between traditional primary care providers and urgent care centers, that tells me that I don't really find any evidence that the quality of care is lower at urgent care centers, and that is increasing the number of visits in the healthcare system. So I don't really find any evidence of that, but it does suggest, because I see an increase in the areas with few primary care physicians, that access to care is increasing. So those areas with capacity constraints, those are experiences increasing in utilization. And that's important from a policy implications. So overall, in terms of the effect of urgent care centers, I'm broadly finding that they increase the efficiency in the healthcare system by slightly reducing costs and increasing utilization in areas where there are few primary care providers per capita. Now, in terms of future work, I have a couple of ideas about urgent care centers. So I would like to kind of empirically look at the effect on emergency department wait times. Also, there's been some concerns about potentially prescribing may be different in the urgent care setting compared to other settings. So one concern has been about antibiotics, and do urgent care centers use the same kind of good practices about antibiotic stewardship compared to other types of practices, and seeing whether that changes. Or potentially opioids, which is another interest area of mine that is also highly policy relevant. And then another thing that I'm thinking about with respect to urgent care centers is the effect of COVID, and whether that has caused urgent care centers to close in the areas that might be least profitable, either because there are fewer insured people there, or because there's just a smaller population, or potentially even because there's more competition in those areas, and that could lead to industry consolidation. And so I think those are future areas of research with respect to urgent care centers that would be really interesting to pursue. And I also have a couple of ideas in terms of the other areas where I have research interests, like opioids and insurance coverage. But that concludes the presentation about urgent care centers. So I'm happy to take any questions about the broader project or my future research at this point.
Thanks very much. I have a couple questions, but I'm going to wait for others to chime in first.
Sounds good. Jason, feel free to ask if maybe some ideas are percolating with the rest of the group. In the meantime, we can talk.
Michal, do you have something?
Sure, I might, if it's okay with you, I'll just ask a quick question, because I think I'm going to have to jump off in just about 4 minutes or so, with apologies. But so my question to you is maybe more just like a big picture one about all of this. So it strikes me that one way of sort of the big takeaway from your analysis here is that given that, as you said, a lot of urgent care clinics are sort of for-profit entities, right? And that, or potentially sort of related to hospital chains that are maybe also interested in reducing the burdens on their emergency departments, that we could interpret your findings by saying they did some pretty good market research before they decided where to open up. And and that market research sort of determines that they should open up in places where they will, have a clientele. Right.
Yeah.
And that what you seem to be showing us is that they did a good job, right? They're pretty successful in terms of getting people to come to them. It doesn't necessarily have that much of an effect on say like the business of other clinics around, but it is sort of providing a service that people in these geographies where the urgent care clinics are located find useful. And so they're going to them, right? And so my question is, this is very much an analysis from the perspective of the owners of the urgent care clinic, right? Like from their perspective, this was a useful business endeavor, and it's providing a service. How do you think about this from the perspective of sort of broader health policy, right? Including especially considerations about, say, like inequality or equity or, access to care. I understand that, you were particularly looking at a population with very high rates of insurance coverage too, but sort of what role do you think urgent care clinics play in sort of the broader healthcare system?
Yeah, I completely agree with that. It looks like they are opening up in areas where people will come and visit them. I think which is what you would want also, because there's no point in opening up a center when nobody comes. But in terms of the effect for the population, I think hopefully what the study also shows is that there are benefits to people, especially in areas that are underserved in terms of the number of physicians, and that opening up these clinics increases the utilization of care in those areas, which hopefully is an indication that some of the barriers in terms of scheduling appointments with physicians are being decreased for people that live in those areas with few primary care physicians. So I think from that perspective, from the patient side, it's also appears to be an improvement, especially in areas where there are few primary care providers. And then with respect to the areas where there's kind of more physicians, it seems to increase kind of the convenience of getting care there, because you have lots of people willing to switch from traditional family medicine practices. And I think that's probably reflective, since there's not really any cost difference or price difference for patients. I think there's pretty good reason to assume that that's reflective of kind of better convenience for patients, even in those urban areas or areas with more primary care physicians. So I think on net, there's evidence that for patients, this improves their welfare. It's not, a huge game changer that gets everybody out of the emergency rooms, but kind of along the edges for some of these primary care treatable conditions, it is useful.
So I think you might want to be careful in talking about it as people switching to urgent care centers rather than going to clinics, because people still have their primary, right? Like for most of these people, they're not dropping their PCP in order to go to urgent care. They go to urgent care when their PCP can't see them, but they still probably value having a family physician who, say, knows about.
Absolutely, yes. Sorry, I didn't mean to cut you off there. what I was going to say is I completely agree there. You know, PCPs are still the majority of the market, and also the reason why I was referring to it as switching was because it looks like the utilization of you know, the traditional providers goes down, and so kind of in the counterfactual scenario, at least for these types of conditions, it appears that the people that are using the urgent care, or at least a substantial portion of them, would have gone to their primary care providers otherwise. But that doesn't mean that they drop them completely, right? With things like chronic conditions, for example, urgent care centers do not focus on those conditions. I've looked at them a little bit, and there's basically not really any effect. People are continuing to get lots of good care from their primary care physicians, and it's not like they're completely dropping them. So I didn't mean to give that impression.
No, it's more just a thought of like this seems to represent, you know, sort of a supplementation.
Yes.
Rather than sort of a shift away, right? And it sort of suggests that people are, you know, it goes back to that question of whether people would use these urgent care centers if, say, the primary care, the overall healthcare system made going to a primary care like better, right, or easier if there weren't as long wealth times. So it's sort of the issue is the way that the system, the healthcare system is set up that kind of presents barriers to people to access care at their PCP, and so this urgent care centers have risen to basically provide an alternative, right? Which I think maybe also gets to why you see a bigger effect on the PCPs rather than the emergency departments, right? Because emergency departments visits are driven by two factors that the UCCs, as I understand now, like don't address, right? One is the particular kinds of, you know, sort of conditions that just can't be treated at an urgent care center. So there you wouldn't expect anything. And two, a lot of things that traditionally was driving ED wait times is the fact that people without insurance use emergency departments as a default for care, but the UCCs are not an option for those people, right? And so the burden that is being placed on the emergency departments by the fact that they're being used as a de facto sort of clinic of last resort for people with no health insurance is not at all being alleviated by the UCC. It just simply means that people without insurance who have sort of smaller, less urgent, who have less urgent issues can now go to these UCCs instead of having to sort of wait in the emergency department while people without insurance and other conditions are being treated.
I think those are great points. And, you know, in Massachusetts, in this context, it's a state with relatively few uninsured people. I think it's like 5% of the population under 65. So it's relatively low compared to other states, but it's definitely true, as you're saying, that those people tend to use emergency departments more. You know, kind of the in-between scenario is with Medicaid, which provides generally lower reimbursement rates, and some urgent cares take it, some don't. I think one of the things that I should have also said in terms of future research directions is I would like to see, you know, whether the story is different for Medicaid, because it's an important part of the system, and it's a place where you know, not all urgent cares take it because the reimbursement is lower. And so it could be potentially an interesting question about what if Medicaid was able to match some of the reimbursement prices as primary insurance or private insurance for urgent care centers. Could that potentially reduce overall care, costs for Medicaid by getting some people out of the emergency department, which is super expensive for Medicaid? So that's another really interesting research question and a direction to consider for urgent care centers.
Great. Thanks very much. And apologies for leaving early, but I got around.
No, of course.
Thanks for your talk.
Thank you for your comments.
Hi. I have a question about the way you set up your treatment.
Sure.
So the choice of 5 miles as the distance threshold, I'm wondering if the urban-rural distinction has any impact on how much effect you can capture, especially in the rural areas, because people in rural areas have less access to care, and they are willing to travel longer distance to access care if there's a new center opens.
Yes.
I wonder if there is a way. So I think a single distance threshold may not be adequate to capture the effects in rural areas. I wonder if there is a way to choose the distance that's adaptive or reflective of the underlying population distribution over the entire state.
Oh, sorry, go ahead.
No, that was my question, yeah.
Okay, yeah. I mean, I completely agree. I think this methodology is in some sense driven by simplicity. And also that's why I kind of also look at the different levels of distance with the understanding that, and I didn't mention this point on the slide where I talked about kind of areas with fewer primary care physicians, but those tend to be in areas that are, less urban. And, one thing that we see there is that people are traveling further in order to get to urgent care centers. And that could really be a reflection also just of, as you were talking about, the accessibility and just also the costs of travel are different in areas that are rural versus urban. There's less traffic. It's more dependent on driving, and so to a certain extent, I do pick that up using the different distance thresholds that I look at. But one thing that I've thought about doing would also be doing an alternative specification based on the driving times, like from a Google API or something like that, where I calculate kind of the average driving time in a zip code to the urgent care center location or the nearest urgent care center. And that's something that I'm kind of considering as an alternative measure or robustness check. So I completely agree with your point.
Thank you.
I think we're right at 1:30. So I thank Giacomo for his great discussion, and thanks for spending part of your day with us. And thank everyone for coming and hearing a great talk. And we'll be seeing many of you next week.
Great, thank you all. I really appreciated the chance to present and get all your comments. So thanks all and have a great day.